Hello, I'd like to welcome you to today's panel on the Affordable Care Act in California, sponsored by the Scholars Strategy Network and the UC Berkeley Labor Center. My name is Drew Hoffman. I teach sociology at UC Davis. I'm also one of the coordinators of the Scholars Strategy Network in the Bay Area. I want to say a few thank yous before we get started. First to Ken Jacobs and the Labor Center for co-sponsoring and hosting this event. I wanted to thank Margaret Weir and Paul Pearson, my fellow coordinators, also Sandy Olgerson and Teresa Jackson from the Labor Center, and Christy Behringer from UC Davis. I want to thank our panelists for being here, and finally I want to thank Lisa Alaferis from KQED for moderating the panel. Lisa is a healthcare reporter for KQED's The California Report and the editor of KQED's State of Health blog. I often wake up to your voice in the morning, so I'm very happy to see you. She's also developed a really excellent consumer guide to the Affordable Care Act that's on the KQED website. I've read it, and I think it's the best guide I've seen so far.
It's also available in Spanish.
Oh, great. Fantastic.
Thank you. I will say I'm delighted to be here. In my line of work, we refer to the ACA as the Full Employment for Health Journalists Act. So I'd like to start, and we're very grateful for it. So I'm sure there's some people on the podium who are pretty grateful for it too. So first I'd like to start by introducing Larry Jacobs. He holds the Walter F. and Joan Mondale Chair for Political Studies at the University of Minnesota, where he is also the director of the Center for the Study of Politics and Governance. He serves on the Scholars Strategy Network Steering Committee and leads the Minneapolis-St. Paul Regional Network. He has published 14 books and scores of articles on public policy and public opinion, including healthcare reform and American politics with Theta Skocpol. I'm going to go straight down and introduce everyone, and then they'll start over with their presentations. Okay. Anthony Wright. He is the executive director of Health Access California, a statewide healthcare consumer advocacy coalition that has led state and national efforts to advance comprehensive health reform. Ken Jacobs is chair of the UC Berkeley Labor Center. Along with colleagues at UCLA, he is leading a multi-campus program to provide research and technical assistance to consumer stakeholders, unions, and policymakers on implementation of the Affordable Care Act in California. Margaret Weir is professor of political science and sociology here at UC Berkeley and one of the leaders of SSN Bay Area. Her work examines the politics of poverty and social policy in the United States, particularly at the state and local levels. And finally, Charlie Eaton. He's a PhD candidate in the sociology department at UC Berkeley. He studies inequality, labor, and the politics of the American welfare state with a focus on healthcare and higher education. Welcome, panelists. And just a quick overview is each member of the panel will give a short presentation, and then it will be some with PowerPoint presentations, and then it will be followed by Q&A at the end.
So I'm just going to roll through some slides here. And the big picture I want to give you is what's going on around the country. And California is, of course, the poster child for how to do it right. Unfortunately, even with California doing it right, health reform is going to fall far short if we don't see other states and the federal government doing a much better job. Part of the challenge is encouraging reform in states where Republicans control part of all the government. Because currently, Republicans are in control of part of of 2/3 of the states, and that is likely to maintain largely through the midterm elections. So it's a real challenge. So where are we right now? And I think this is kind of a helpful point given how terrible the fall was with the disastrous rollout in Washington and many states, but not California. Now, Charlie Gaba has been kind of tracking numbers of enrollment through the exchange, the Medicare and Child Health Insurance Program, and then the program of expanding insurance coverage to young Americans under 26 whose parents have coverage. And that number is already up over 14 million. Now that's a pretty large number. If you think of like Northern Europe, for instance, that is all of Northern Europe. So this isn't like a trivial situation. This is Norway, Denmark, et cetera. I mean, this is a substantial number of people who are now being covered, and it's growing. The Congressional Budget Office came out with a report last month that got a lot of coverage on a non-issue, which was the mistaken notion it was that the ACA was leading to the loss of jobs. That was completely erroneous. But it's a fascinating report, and I think one of the most important things in the report is that it is now projecting over the next few years that just the exchanges at the federal level and state level will encompass 25 million people. If you add in the expansion of Medicaid, it's up near 40 million people. That is a phenomenal increase, and the train has left the station on this. So the big question is, what is the future going to look like in the coming years? On the exchanges, we have 16 states that have adopted them. Quite unfortunately, about half those states are really not doing a good job, and they're either going to have to come up with new vendors, or, and I think this is a reasonable proposition, they might consider joining the federal exchange, which is now working much better. But the good news here is that the way that the Affordable Care Act was designed, there's a fallback to the federal government. The big challenge is on Medicaid, where we have about half the country covered and about half not covered. If the states do not cover Medicaid, it's their option, but it will leave about 5 million people in the lurch. And this is very significant. There's a new study just came out recently from a group of people at Harvard, and it shows the consequences of not expanding Medicaid. Within 12 months, about 500,000 American women will go without Pap smears. Texas is one of the worst cases of the cost of inaction. Over 100,000 women within a year are going to not have the necessary preventive coverage. When you look at catastrophic costs from health care, we're looking at about 250,000 people who are going to be facing that disastrous impact on their families. Preventable deaths, which is really, in many ways, the harshest consequences of politics and ideology trumping pragmatism, is going to be stunning. The Harvard group estimates somewhere between 7,000 and 17,000 Americans will lose their life because states are not expanding Medicaid. This is just remarkable. So it is very important to figure out what are the dynamics by which Medicaid might be being expanded in states where it's already happening. And so I've been working with a graduate student at the University of Minnesota, Tim Callahan, tracking progress, not just kind of states saying yes or no to Medicaid, but a kind of a string of different steps along the way that states have had to go through in terms of making progress with Medicaid. Everything from getting federal grants to negotiating with the federal government for waivers, we've seen in some states, and then adopting expansion. And what we're finding is a very interesting pattern. It is not simply the Washington kind of stalemate between the two parties. There are some factors that are emerging that are moderating the kind of Republican unified front against health reform and Medicaid expansion. There are currently eight Republican governors have adopted or pushed through health reform, and it looks as if that number could grow maybe even double the next year or so. So it's really quite dramatic. And as I said at the outset, very important. So what might be some of the factors that would lead states to expand Medicaid? And I'm just going to roll through these very quickly and glad to come back later. One factor is it may just be the generosity of Medicaid. 3 years, 100% funding from the federal government. Afterwards, it ratchets down to 90%. That is a credible deal, and there's more in there. And you might think that states that need the money might be the most interested in it. This is just a kind of correlation that shows maybe that's not the case. I'll talk more about that in a second. One thing that's very important is to look at what is an emerging division that's broken out between more pragmatic governors looking statewide who are responsive to business, to hospital organizations, to citizen and public interest groups, versus what is often a Tea Party-laden, take no prisoners, refusenick faction in the legislatures where they're dominant. So here you can see the legislature really being, Republican legislatures being a stalwart opponent. Now one factor, and Paul Pierson's been a leader in this, that you might expect would have some influence in the expansion of Medicaid is simply the fact that states have experience in working with Medicaid. You think of the expansion in New Mexico, where you have a conservative Republican governor, or even in Wisconsin with Scott Walker, they've expanded Medicaid, as have other Republicans, and it's not a surprise that it's those states that have a long history in building programs that have provided in healthcare and other areas support for those who are vulnerable. States have to have the administrative capacity to move forward, and that's a factor. Perhaps there's some influence of experience negotiating with the federal government. Rick Perry describes the Affordable Care Act as a take it or leave it, it's being jammed down your throat. That's absurd. That's just not the way in which intergovernmental relations work. We've seen Scott Walker cut an incredible deal, and as has other Republican governors in the negotiations. Public advocates are also a very important factor. And I know you've seen this in California, but it's also the case that a number of other states, including Republican-controlled states, we've seen public interest groups, citizen advocates organizing and being a real presence. So I'm not going to go through all this, but we ran some statistical analysis. This is a regression analysis. And the bottom line here is that the Republican legislatures are a real stumbling block for reforming health reform and expanding Medicaid. The governors are not. So this kind of confirms what you see around the country. What is also really striking is that the advocacy organization is a significant influence in the expansion of Medicaid. And it is the states that are able to organize, and the foundations and other groups that have been investing in that, it's well worthwhile. The history of states in terms of their past policy is also a factor. Now, I just want to kind of draw out a few lessons here, and then I'll conclude. Clearly, this division that's breaking out in Republican ranks is something to focus on carefully. These are not the same Republicans in all parts of government. And Republican governors, and if you follow, for instance, the Republican National Governors Association, you hear it all the time, are quite pragmatic. And it's coming from a lot of different sources, again, including hospitals that are faced with some really agonizing choices that could threaten and shut them down. The advocacy organizing is absolutely important, and sometimes I worry that in the way in which we talk about the Affordable Care Act as kind of doomed to party government, we're demobilizing people. It's just the opposite story. People need to be mobilized, and the fact that you've got states with rich policy trajectories and experience creates some real opportunities for entrepreneurs to really tap into repertoires of reform. So I want to just conclude with a few final points, which is we think of the ACA as the reform, but this is actually creating a new platform for reform moving into the future. This is a kind of reset. One important point to appreciate is that at this moment, when you look at polling about support or favorability of the Affordable Care Act, you see pretty consistently that Americans tend to be less favorable and more opposed to reform than not. But it's also important to realize that people are not aware of many of the parts of the reforms. So they were opposed to Obamacare, but they don't know the reforms that are actually in the bill, and things like requiring or providing individuals with subsidies. It's only known by about half of Americans, and yet it's supported by over 70%. The idea of imposing new rules on insurers that they have to spend at least 85% of their premiums on health and improving health is known it's only known by about 40% of Americans, even though it's quite popular with 62% favoring it. This goes on and on. So the point here is that we've got a real problem where Americans are not aware of what's in Obamacare, even though they support the reforms that it's bringing about. Some colleagues at Stanford have done a nice study, and they, in a very elegant way, show you the impact of people becoming more knowledgeable about reform. And in this simulation, what it shows is when people are fully knowledgeable, which is an ideal, you can see reform among Republicans approaching 90%, among independents 80%, and even among Republicans rising close to 50%. Now, we're not going to reach those levels, but it's quite possible that we can do some serious revision and reversing. Now, even though people have questions and are doubtful about Obamacare, they do not support repeal. And this is one of the more important points, because Republicans sometimes equate lack of support for Obamacare as support for repeal. Those are very different. In fact, we now find that there's this pretty steady majority wanting to keep the Affordable Care Act. Okay, second quick point, which is there's a 24/7 news cycle on Obamacare with every news release seeming to be kind of, is health reform going to fail or not? That's really not a very helpful perspective. You look back at Social Security, it took about 40 years for that law to get locked into place. During World War II, there were the kind of repealers who took the decision to suspend Social Security during the war as an opportunity to outright kill the law. And it really wasn't until the 70s that you saw Social Security lock in. So this is going to be a long struggle, and it's one that people, yeah, it's a full.
Don't hang your head now.
Well,
Just getting out of the start line.
pace yourself, my friend. Now, here's my last point. My last point is, as we think about where we are today, we ought to be thinking about where we will be, because there are going to be other moments. Maybe not around the corner, but 5 or 10 years, there'll be other episodes in which health reform will come back out. And what is happening today is creating new platforms, new developmental paths that health reform can go on, along. Medicaid expansion that's spreading even to Republican states is creating new opportunities. I was in New Mexico yesterday, and there are a lot of very well organized citizen groups who are very concerned about health disparities, particularly on Native American lands. And they see the Medicaid expansion as the most powerful weapon they have, particularly now that the federal government is bringing in so much money. The decision of the ACA designers to give states so much opportunity is also given progressive states the opportunity to build progressive opportunities as well. Vermont, of course, has passed a single-payer plan. And there's going to be a new waiver process starting in a few years called 1332. Write it down, follow it. California may want to look at that. But the 1332 is the avenue by which states could go back to single payer, go back to the public option, and move the ball forward so that the next episode of big national reform, it's not just Massachusetts. There can be 3 or 4 or more different approaches. Now, I think there's a tremendous historic error that's been made by conservatives who are suffering from a kind of myopia, which is their fervent opposition to the Affordable Care Act now has led so many, almost all, Republican states in terms of the exchange to defer to the national government. And the result is they're creating an enormous capacity in Washington to run exchanges. When you look at those numbers I was mentioning at the outset of 25 million within a few years in the exchange, 37 million when you include Medicaid, that's phenomenal. By comparison, the largest insurer we have, a private insurer, is United. They have 70 million customers. You come down and you're into the 30s or the teens. So the federal government's going to be involved in the largest insurance operations in the country within a few years. That's going to create enormous opportunity and leverage points and new developmental opportunities for reformers the next time we have an opportunity to open this debate. Thank you.
Okay, so thank you, Lisa, and thank you very much. Again, my name is Anthony Wright. I'm the Executive Director of Health Access California. We're the statewide healthcare consumer advocacy coalition. Here's ways that you can reach us at the website, our Facebook, our Twitter, our daily blog. We want to be a resource to you in engaging in the state health policy conversation. I appreciate being on this panel and following Professor Jacobs because, obviously I'm always going to appreciate any academic who talks about the really crucial importance of advocacy organizations. So we appreciate that as well as the Margaret and Charlie's research later. I also very much appreciate the emphasis about the fact that we very much see that this is not the end, this is the beginning. The metaphor that I've said is that we've just come, my current metaphor is that we just come through a four-year pregnancy. And delivery, and as parents know, that's only the beginning of the care and nurturing and development that needs to take place. We recognize that there's all this excitement around conception, but this is where the real work comes happen. So obviously, the Affordable Care Act, it's a really big deal, as the Vice President said. And in major ways with regard to, the biggest thing that Congress has ever done with regard to passing an HMO or insurance patient's Bill of Rights, your consumer protections when dealing with insurance company. It's the biggest effort to secure coverage for those who have it and expand it for those who don't since the creation of Medicaid and Medicare in the 1960s, almost 50 years from now, since. And it's the biggest effort to try to control costs. what I want to talk about a little bit is what California has done, because, and it really is an impressive amount of work, not just to pass it here in California, of which my organization was a leader in the Healthcare for America Now effort to pass it, but also in these last 4 years to pass the 24+ bills to get it implemented in our state statutes, to get set up the exchange, to do all the sort of mechanical things so that people have access to the new consumer protections, new financial assistance. Yesterday was the announcement that now 3 million Californians are enrolled in the new options under the Affordable Care Act. Over 900,000 in covered California, just over 2 million in Medicaid. And that is partially because we have, as has been stated, we just didn't see this as an implementation effort. We saw this as implement and improve. And so let me just highlight a couple of areas where California took either the options of the Affordable Care Act to another level or built upon it for something for new. So some things we did early. We actually expanded Medicaid early through county-based low-income health programs. 53 of our 58 counties decided to take Medicaid money early to start getting people enrolled. And as of January 1 of this year, we had 650,000 Californians who had been in coverage for months and in some cases a couple of years, automatically transferred into full Medi-Cal on day 1, January 1, 2014. And so, you know, whereas everybody was just starting at the starting gate, California had already had, 650,000 people banked, already getting care, and then transferred into a full Medicaid service. So really impressive. Only 5 other states took up that early Medicaid option, and the next biggest one was in the tens of thousands. So that's an example of just California doing something way beyond other states. Another example, and I think this is one where I think this is indicative, is we went early with children with pre-existing conditions. In the Affordable Care Act, no one is allowed to be denied for pre-existing conditions starting this year, 2014, but it started early, so in September 2010 for children. However, when the insurers found that, okay, wait a minute, we have to cover children, including all the sick kids too, maybe we don't want to cover children at all. And they started withdrawing from the market child-only health policies. And we were at a moment in late 2010 when actually there was less access for children to get access to coverage because insurers were taking that off the market. So we actually sponsored a bill by Assemblyman Mike Feuer that was signed into law by Governor Schwarzenegger that said, if you do not offer child-only policies, then you are not allowed to sell to adults either for 5 years. And lo and behold, on January 1, 2011, all the insurers came back into the market with child-only policies. And we also had another provision in the law that said, and we want to put a limit on how much those kids can be charged compared to healthy kids until we get to 2014 when you can't do any underwriting altogether. And so that's an example where, we talk about governors or administrations that are hostile to the ACA, but benign neglect isn't good either. That in fact, there's all sorts of opportunities to find loopholes, to find problems that in order for us to really fulfill the promise of these laws, it needs an active engagement in implementing in order for it to work. And that means, thankfully, we had the political will here in California between even a Republican governor at that time, but also a legislature, regulators, et cetera, to try to close loopholes and make this work in its intent. We also put in place the maternity coverage mandate 18 months earlier. Some things that we did beyond the Affordable Care Act requirements. Covered California is actually there are 17 state-based exchanges, marketplaces, but California is only one of a handful that is allowed to be a true active purchaser, to use the bargaining power of the people who are in it to really negotiate for the best possible price. And it uses that power not only to do that, but also to standardize plans so that you can get true apples-to-apples comparisons for consumers, so that for those of you who have been on the site, the silver-level plans or the gold-level plans truly are the same between the Kaiser and the Anthem and the HealthNet plan, and that allows for better price competition and for easier experience for consumers. That's a real example of California taking another step beyond what the ACA did. We very excitingly, we use express lane enrollment options for example, identify 700,000+ people on our CalFresh food stamp program who are eligible but not enrolled in Medi-Cal, sending them notices so they can automatically sign up for Medi-Cal with a quick click or call or post-it card. And then we've done some remarkable things, including using state dollars to include recent legal immigrants and other immigrants that are otherwise excluded from the Affordable Care Act in California's implementation. So that gives you an example of how even in the last couple of years, notwithstanding some of the additional things that we can do in the future, California has taken steps beyond the Affordable Care Act, using it as a platform, but to go further, especially given the severity of the issues here in California. And why is this important? Well, because California is unique in a couple ways. We are leading, I think it's pretty clear that we are leading the nation. It is interesting for me to be in conferences with my brethren advocates from other states, where they're talking about, again, resistance to the Medicaid expansion or to technical issues and some of the other issues. But one of the things that's remarkable about California is that it's leading even in a position where it has such a significant issue. I like to joke that when a lot of tension was going on in Massachusetts with regard to its health reform, we were always very interested in the Massachusetts health reform, since called Romney Care. But we were saying, well, okay, so that's 6 million people. Okay, so then California has more uninsured people than Massachusetts has people. And they had a 10% uninsured rate when they started their reform. Now they have it down to 1 or 2%. We had a 19-20% uninsured rate when we're starting. So they were closing a gap. We're jumping a chasm. And it's indicative of the top 12 states with the biggest uninsured rates, we're the only one with a Democratic governor. So we're the test case for how to do, not only how to lead on this, but how to lead this in a state with a really big issue, with a really big problem. That it's one thing to try to figure this out in some of the northern states that have relatively lower uninsured rates. It's another thing to try to do this on the scale and the complexity and the diversity and the acuity of the problem that is Massachusetts, that is California. So states need to make it work, as noted health policy expert Tim Gunn says. And we recognize that this is, there's so much attention on us. Here's several quotes from noted DC people talking about if the ACA can't succeed if California fails. So we got the pressure, we got it. And I think the biggest thing, let me take that off. So the final thing I would say is, and I'll leave this to Ken to talk about this, is, we're not stopping here. There is a significant amount of work that we're not satisfied. We're excited about the progress, but whether it's even getting the systems to work, we've had our own website glitches. It shouldn't take half an hour or more to get somebody on the damn line when you call Covered California. That we need to have a better quality ratings and provider search tools and better Latino outreach and 5 other things. We also need to go further with regard to it. And I would say this, especially in the context, which is, I think it's an interesting question about why did we get into this, why are we in this leadership position? And it does have to do with, I think, a whole bunch of factors, which I think some of the other panelists will talk about as well. But it is a tribute to the institutional and political forces that have aligned to allow for this, whether it is, the fact that we've had all political leaders from that are supportive of the ACA in power in California or other things. But you have a situation where we have a governor who has been focused on other issues in the last several years. I mean, he had a budget crisis to deal with. He has not made healthcare a major focus. He has not spoken very much about healthcare very much in his tenure. And so at some level, this is an interesting case where when there's so much press attention on gubernatorial leadership, in fact, it's been the fact of what is the institutional play of the power in the legislature, what is the consensus of the health industry, what is the advocacy and organizing going on that has been the difference to get California to not only to implement the law, but to improve upon it, and that's what we're going to hope to continue to do. Thank you.
Thanks, Drew, for organizing this today and bringing us together, and thanks, Anthony, for explaining why no one's had any sleep for the last 2 years. So I'm going to talk a little bit about the work we've been doing with Covered California around implementation, specifically the research work and data analysis we've been doing with them, and then talk about sort of where things are going from here. So one of the things that really stands out about Covered California is how data-driven they are. And as each issue's come up, they've really been very interested in kind of drilling down as far as they can to understand what's the population that is potentially going to be covered and that they're going to be able to bring in, what are the demographics, where are they geographically, all in terms of designing their strategies and doing the outreach and bringing people in, but also figuring out in terms of their long-term financial sustainability, et cetera. And as issues have come up, they've really asked and looked and done very good work working with a number of people around the country in terms of figuring out the steps they need to take. So one of the things we've been working with them on, we have the California Simulation of Insurance Markets model, CalSIM, that was developed by people here and with the UC Berkeley Labor Center and the UCLA Center for Health Policy Research, and done with support of the California Endowment. And what the simulation model is designed to do is to predict the impacts of the Affordable Care Act on employer decisions to offer coverage and individual decisions to take up coverage in order to get an idea of how many people in the end will end up in job-based coverage, in Medi-Cal, in Covered California, uninsured, et cetera. So this is a snapshot of some of the analysis that we have done for them. And these are 2019 prediction numbers, and one of the reasons we put up 2019 is because we estimate that it'll take 3 to 5 years for all of this to phase in. Now, when you watch the news with the 24-hour news cycle and everyone twittering numbers constantly and talking about, are we at projections yet, this is just a little bit of a caution that all along, I think we all understood that this was going to take time, that it'd take a number of years to roll in, for decisions to be made, for people to ramp up, and that's been true with other similar programs. So overall, our initial projections have been that we'd see a small decline in job-based coverage. Some people will go and take up coverage. There's now an individual mandate, so some firms will decide to offer it because their employees want it more. Some individuals will take up coverage on the job that they were offered before and had not taken up. And on the other side, some firms will decide to drop coverage because they have lots of low-wage workers who now are eligible for subsidies, and that'll mainly be with part-time workers, as we've seen Target, Walmart, Trader Joe's all decided to drop coverage for people under 30 hours. Our initial Medi-Cal predictions were 1 million to 1.4 million, and people in Covered California with subsidies 1.7 to 2.1, and again, that's in 2019. You'll notice at the bottom that we're predicting, again, a continued 3 to 4 million remaining uninsured, even after the law is fully implemented, and I'm going to come back to that in a minute. So what's happened so far? These are the figures reported by Covered California recently. So that's 880,000 enrolled at the end of February. That's now over 900,000 as of March 9th. 762,000 of the 880 were subsidy eligible. 1.1 million determined eligible for Medi-Cal. And I guess this is all, around 25% of national enrollments are in California, just in terms of how much the state overall stands out. Our projection, comparing this to our projections for 2014, we estimated that by the end of this year, we'd have 840,000 to 1.2 million at a point in time in the exchange, but that would be at one point in time. And I think one of the things that's important to note here is, and I'll get back to this in a minute, that there's quite a bit of churn in the individual market. People come in and people leave. And what that means is the number who are enrolled in October, we wouldn't expect all of them to still be here right now. And so is there some of this discussion about the number of people who haven't paid? Some of those may be people who enrolled in October and by the time January came around had found a job and that had job-based coverage and no longer needed coverage. We really don't have the details there. But I want to emphasize that the numbers of enrollees tells us a certain amount, but it doesn't tell us everything. And it really isn't until we have other data later this year. The current population survey will be out in the fall. We may get some reports later from the Department of Managed Healthcare and the Department of Insurance that will really have a sense of what change has looked like from before and after when reform went into effect. So this it's indicative because it shows us we know something about enrollments, but it'll take longer till we really know what's happening in terms of change, and it'll really be a few years before we have a good analysis because all change has to be understood in the context of trends. Job-based coverage has been dropping by 1% a year for the last decade, and so, again, you have to understand what's going on in the context of what's been happening. One of the things we do know is Latino enrollment has been behind projections. It's picked up a bit recently, but this gives you our original projections for eligibility and where we saw enrollment. And we did project Latino enrollment potentially being behind the eligibility, largely because of there's good evidence around non-native English speakers enrolling in programs at a lower rate. And that was something that could be fixed with good Spanish language outreach, but you can see overall enrollment projections, they're high for Asian and Pacific Islanders, higher than we had projected, and lower in terms of Latinos. And for that reason, and because this has been covered, California's been tracking this closely, they've really ramped up the Latino outreach in recent months. And we'll see how that goes and what it looks like after the end of March. So, even as all is said and done by the end of 2019, we project there'll still be about 3 to 4 million remaining uninsured. So the Affordable Care Act does a tremendous amount to expand coverage in the United States, expand coverage in California, but it doesn't cover everybody. Of those remaining uninsured, a quarter to a third will be people who are undocumented and so are not eligible for any programs. We'll have some people who are eligible for Medi-Cal but have not taken it up. Current take-up rates for Medi-Cal are about 60%. We think that can go higher, 75%, with better and more automatic re-enrollment and making the process easier. But for people who are eligible for Medi-Cal, when they show up and need care, they'll be able to enroll at that time. For people who are eligible for subsidies or for Covered California without subsidies who don't take it up, they'll be able to enroll again in an open enrollment period, or if they have a life transition. But what's important here is for people who don't enroll, and if they don't have a life transition, they will be left out of coverage until the next open enrollment period. And the other thing to note is the way the law is done, there are some glitches and holes where there are people who just will not qualify for an affordable offer of coverage. So, what's being done or what can be done to cover the remaining uninsured? First, California took a very important step, and one of the few states who has done this, and that is the Dreamers, young adults, adolescents and young adults who are eligible for deferred action for childhood arrivals. So those are people who came to the came to the United States as undocumented immigrants as children and stayed here and are either in school or have graduated from high school. They are eligible for state-only Medi-Cal in California, and we estimate there are about 125,000 now who are currently eligible. And so one of the things we're very interested in is looking and tracking and seeing what that enrollment looks like. Do people not enroll out of fear? Our recent research suggests very few right now are aware that they're eligible and aware that the program is open to them. And so one of the key issues here is going to be getting that word out. Second, Senator Lara has proposed a bill that would cover all undocumented immigrants. And it would do state-only Medi-Cal for undocumented immigrants who are under 138% of the federal poverty level, and then create a mirror exchange with subsidies for people who are over that level. And so that discussion is starting to happen in the state right now. The third thing is there are a number of county programs, and certain counties, a number of Bay Area counties and Los Angeles, have programs that are open, they're really health access programs, not necessarily insurance, that are open to undocumented immigrants. And then finally, we've got our social safety net systems, which will continue to be important for all of the people who fall out and remain uninsured, regardless of their documentation status. And so one of the key things here is this hasn't resolved all the problems. The social safety net systems, the public hospital systems, all of that will still need to be maintained to cover those people who are not in reform. And I have to say, as Anthony discussed all the things California has done in terms of real leadership in implementing the exchange, And implementing health reform overall, the other place that California is really stepping out is looking at what can be done to cover people who are not covered through the Affordable Care Act. So one last quick point mentioned earlier, enrollment doesn't end with open enrollment. The individual market is a place where some people go and stay for a long period of time. People who are self-employed will go and stay there. Many other people roll through the individual market. You have a job, you lose the job. Right now, you might go on to COBRA, but a lot of people don't because it's expensive. Now, exchange will be a good opportunity, get subsidies, pick up coverage in the exchange, get another job, leave, go back to job-based coverage. So there's quite a bit of churn. So we estimate that just a little more than half of people who are there at the beginning of the year in the exchange will still be there at the end of the year, which means there's going to be a lot of fluctuation in people going through life transitions and continuing to enroll. So the exchange will need to be there and continuing its work and continuing to do that enrollment work throughout the year. You know, I know everybody's ready to, you know, take a breath, relax, and sleep a little bit after April 1st, but the point is there will be a lot of work in terms of enrollment that will continue through the year. Our estimates on Medi-Cal is that it's a little more stable, 75% remain. There was just a national report that came out where they also estimated about 50%. So we'll see where that goes. And that's it. Thank you.
So our comments, our being me and Charlie, will be based on a paper that we wrote that examines the rise of a broad coalition in California to defend the public interest or consumer interest in healthcare. And I'm just going to give a little intro to it, and Charlie is going to present our work. And I'll just say that we became interested in this issue because in the early 80s, as we looked at the trajectory of healthcare in California, in the early 80s, there were key decisions made about the controlling costs in California, and they were made in a closed context with business and government leaders. There were no advocates, no labor people, no consumers represented. But by the time Schwarzenegger was considering universal care in 2009, advocates were at the table. They were one of the, in a small group, consumers had a big voice, Anthony's organization. So we became interested, how did this happen? And in terms of the literature on the welfare state, there's a lot of work that talks about the public-private welfare state, which of course healthcare is part of, that talks about how hard it is to get the public voice in. It's so hard to get the consumer voice in. So what we wanted to do was provide an account of how did California build this coalition, consumer coalition, over time. What were the pieces of it, and how did it grow? And that's what we do in our paper. And in talking about advocacy groups and what they do and advocacy coalitions, we highlight three things. And we highlight their capabilities in terms of technical expertise, so that in the early 80s, the discussion about how to control costs was a technical discussion that no advocates really had the expertise to be part of. We highlight grassroots mobilization, especially in places like California. You need to be able to engage in the propositions and bring people out to defend the gains that have been made. And we also highlight the role of advocacy in monitoring implementation, because there may be benefits that are promised, but when you come right down to the delivery of the system, those benefits aren't there. And so monitoring and a monitoring voice that can go back up to correct the flaws in implementation are some of the things that we highlight. So Charlie's going to present in a very few minutes the research that we did.
So, Margaret talked about those things that advocates do that make a difference for healthcare reform and implementing healthcare reform. And those capacities that she talked about, whether it's lobbying, whether it's technical policy expertise, whether it's grassroots mobilization, what we found is that there are three key ways that, or three key aspects of the public-private welfare state that consumers and advocates can exploit to develop those capacities. So these were the three vulnerabilities that we see in the public-private welfare state. The first is shifting interests, meaning that as different private actors are posturing and changing policy to themselves provide services and receive funding, interests shift. Secondly, there are inevitable service gaps in which people fall through the cracks and don't receive the services that society would expect them to. And third is that provision of public resources to private groups creates opportunities for advocates to capture those resources and use them for advocacy. So it's really key to understand that to exploit these three vulnerabilities, forming a coalition is very, very important. For example, in the case of shifting interests in the public-private welfare state are really diffuse, so you need a coalition to align those interests. A key example here is labor. In the 1980s, after a deregulation of California's hospital rate setting, hospital workers were hit by service cuts. They also, consumers were heavily hit, and there was a phenomenon called patient dumping, where hospitals were denying care to, emergency care to people without insurance. And it was around that issue where both labor and consumers were affected that Health Access was originally formed, Anthony's coalition. And what Health Access essentially did was it institutionalized that alignment of interest between labor and consumers. It's not the only thing Health Access does, but it's an important thing. Secondly, on this, service gaps are also very diffuse. And service gaps are uneven. So you need a coalition that can unite affected communities across racial, class, and other lines. And to give you a picture, here is Anthony's board of directors. So it gives you a sense, right, of the types of labor organizations from SEIU, which represents many healthcare providers, as does AFSCME, the California Teachers Association and American Federation of Teachers, which also represent healthcare workers in schools, but they also represent many non-healthcare workers. And then you have more consumer-oriented groups, Planned Parenthood, Congress of California Seniors, Alliance of Californians for Community Empowerment, an organization of low-income people, especially in communities of color. So you need a coalition that can unite these people who are affected in such diverse ways by the service gaps that occur in the public-private welfare state. Now that this third vulnerability of the welfare state that can be exploited is capturing these resources from public-private welfare programs and using them for advocacy. Now, there are many ways that advocates can do that, but a very important one that we'll talk about and that we talk about a lot in our paper is the creation of the California Endowment. It's a classic case of this. You might have noticed on Ken's presentation, he said that their research was funded by the California Endowment. So in a way, because of the creation of the California Endowment, you get the type of advocacy supportive work that Ken has done. And here's what happened. Amid shifts in the healthcare system, Blue Cross of California, which used to be a major nonprofit insurer, decided that they wanted to become for-profit. But advocates said, with particular leadership from the organization Consumers Union, which, are they on your board? Yep. Yeah, they are. Consumers Union said, wait, not so fast. You're a nonprofit organization. That means you've received decades and billions of dollars in tax subsidies and tax exemptions. That means you have public assets. You can't just take those and use them for profit. And they said, rather, what we want you to do, our policy proposal, is that money should fund a foundation that should be for improving healthcare. And by the way, we want to run the foundation. So, lots of details involved, but long story short, so was born the California Endowment with a board that has been overwhelmingly supportive of healthcare reform and overwhelmingly aligned with consumers. Now, this is another part of Anthony's organization. This is their C3, which doesn't do the political stuff. I put this up here to another point about aligning interests. You see on Anthony's board, you've got folks from the healthcare provider community, not just the advocacy community and grassroots organizations. Health Access's ability to bring these groups together from the provider side together with folks from the grassroots and consumer side. It's another example of how you can, as interests shift, you can bring people together. Now, these are some of the things that consumers bring together in their coalition. They bring firsthand knowledge of service gaps, not caps, in diverse communities. And that firsthand knowledge provides credibility for policy arguments. Healthcare unions also have firsthand knowledge as service providers. And labor, more broadly, particularly provides capacity for grassroots mobilization, lobbying, and elections. So these are some of the resources that the coalition can bring together. I want to make another point about the California Endowment, though, before I close. So this is a poster on a billboard on 51st Street, paid for by the California Endowment. You can't really see it too well, but there's a logo for the California Pan-Ethnic Health Network in the upper left-hand corner of that poster. And this is a good visual representation of the very diverse organizations and communities that the California Endowment has funded. Now, here's a test for some folks. Can anybody tell me what all of these organizations have in common? They all received money from the California Endowment, but what else? They also were 20 of the 23 organizations that were community-based organizations that first received the first covered California grants for enrolling people in healthcare. So there were 23 organizations in California that received covered California grants. Those are the grants that go out and enroll people in the exchanges, enroll people in Medicaid, answer consumer questions, assist them when they have problems. Of those 23 community organizations, 20 of them received 158 grants, which totaled, I don't remember how much, I don't have the total right in front of me, totaled many millions of dollars. Yeah, 45 million-ish. So many of these organizations had built their capacity to do this kind of enrollment work with the covered California grants by receiving funds from the California Endowment and engaging in many other healthcare policy-related struggles beforehand. And in a way, you can think of these covered California grants as themselves another way of providing more resources to advocacy groups from the public-private welfare state that is helping them build their capacity to advocate for further expansion of healthcare and particularly further expansion of the public in healthcare. And do you have anything else to add, Margaret?
I think we should open it up.
Then I'll close there. Thank you.
Well, we have a question right in the front row.
Yeah, I was wondering if I could speak for a minute. My background is 15 years in the health insurance business. And
Excuse me, sir. Could you please speak into the microphone? We're recording.
if it's okay with you.
You've
not invited anybody here from a union or anybody that opposes Obamacare, including nurses and doctors. I don't like Obamacare, and I'll explain why.
Sir, I'd be happy to give you a couple of minutes to speak, but so go right ahead. But I will. I was watching the clock on our other speakers, and I was going to applaud them for taking their time. Okay, great.
I've been in the health insurance business for 15 years, and I'm still in it. Okay. I also won the Democratic nomination to the U.S. Congress twice, so I'm not a Republican in any which way or form. However, I know what's happening. My wife had an Aetna policy. She was one of the 1 million Californians that lost her insurance, where Obama said you wouldn't. She paid $290 a month to Aetna. She now pays $514 to Blue Cross. Her deductible went from $2,750 to $5,000 with this lowest, the worst plan, the bronze plan. Her co-insurance went from 20% under Aetna to 40% under Blue Cross. So the so-called Affordability Act is a bunch of baloney. And I predict that as the people see these all these different higher costs to them in the next 7.5 months to the election, the Democrats are going to be ruined, okay? They're going to lose it. They just lost the act in there. We could have prevented it if the Democratic Party had protected the people and expanded Medicare. Doctors and nurses around the country went to a public hearing and...
Can you talk into the microphone, sir, please?
Huh?
Please speak into the microphone so that your voice can be recorded.
Okay. Doctors and nurses went to a public hearing, and Democratic Senator Max Baucus would not let them speak about Medicare, expanding Medicare. In fact, he had them arrested and they went to jail. That is what is happening in our public hearing. These are what's happening in the corruption in government. We need to expand Medicare to all Americans, period.
Okay, thank you, sir. I will say that you make a valid point that many people whose policies were canceled have seen higher prices. I've personally reported on some of those stories on my blog at KQED. We've covered that from the beginning. There are also many other people who are benefiting. And actually, Anthony, I think you would be a good person to address sort of the societal viewpoint, because it was a third of the people whose policies were canceled had good coverage, despite what Paul Krugman likes to keep saying in the New York Times. They had good coverage, and they are paying more.
Yeah, so, I mean, I think the gentleman brings up 2 points. I mean, I think on the specific issue of the plan cancellations, and I mean, I'm happy to talk with you afterwards. There isn't a plan in the exchange that offers 40% coinsurance. So I think there's some just things I'd want to talk through with you about the specifics. But as Lisa said, the president was right when he said that, you know, if you like your plan, you get to keep it. When the bill was signed, the problem is that there was new policies that were introduced afterwards that didn't meet the requirements of the law, and the insurers did seek to change those policies to meet the requirements of the law. Majority of those people did either get better or in many cases cheaper policies, but there was about 200,000 to 300,000 people who did see an increase for policies that were generally quality policies. We chalked it up to the fact that the law didn't go far enough, that in particular, the demographic of that profile was people who are just over the 400% federal poverty level, so 45,000 for an individual, 90,000 for a family of 4. These are people, they typically were older, they typically were in high-cost regions. That includes the Bay Area and San Francisco. We are actually having some conversations in the Capitol about how can we provide some additional help, because there is a recognition that especially in a high cost of living area with high health costs, there maybe needs to go help. When Healthy San Francisco was passed, we went up to 500% FPL, and we would like to see a world where we could say, you know, we give a guarantee to virtually everybody that you don't have to spend more than 9.5% of your income to get a basic coverage. And however, there's a slice just over 400% FPL that we don't provide that guarantee to, and it would be great to extend it. It wouldn't be that much more of a cost to give that basic protection. But to the second point, which is, you know, there was advocacy for more aggressive types of reform, from a public option to single payer. I know some people in the room are longtime advocates of a universal single payer healthcare system. Health Access was founded and continues to be supportive of a universal single payer healthcare system. So we have to balance the fact that what we got out of the Congress was the biggest thing it ever has done, and it wasn't all that we asked for. And we have to continually, and from my point of view, it's not like we had lots of votes to spare on either the House or the Senate side. At the same time, and that's why I'm excited about the prospect of using California as a platform to take additional steps, as Ken has suggested, and as Larry suggested with the 1332 waiver in 2017.
So Ken, along those lines, it might be interesting for people, do you have some analysis of people who have your projections about how many people will be covered and will be can you just recap the subsidy eligible people who will be getting insurance and be subsidized, what those numbers look like in California?
Our original estimates were that there'd be, by 2019, 1.7 to 2.1 million people in California receiving subsidies. Now, we are revising those estimates downward, and the reason we're revising those estimates downward is for a good thing, which is the premium costs in covered California are about 20% lower than projection. And because the premium costs were 20% lower than projection, and subsidies are based on what percent of your income do you need to buy coverage, if the premiums are cheaper, there are a set of people who no longer will have subsidies in order to get coverage because it'll be under that level. So we haven't finished doing it. We're getting close, but overall we're pulling those numbers back a little bit. But in general, you're talking a good number of people who will be receiving subsidies. Plus, you've got the people who'll be in Medi-Cal. Again, we had projected 1 to 1.4 million because California did such a good job with the low-income health program, and 650,000 people rolled over right into it. There are they also count in that group. But overall, if we look at people who are starting in the individual market, because this is the situation you described, about half of them will receive subsidies. Some of the people who started in the individual market are finding cheaper plans, and I know for any number of cases of that, even if they're not getting subsidies, because of the way age rating works, other factors, they were able to get better plans at a lower cost. And then there are other people who, because they had a certain plan at a good cost, are paying more. So it's played out as a bit of a mix, but overall, the number of people who are gaining support to get care is much larger than the number of people who are paying more.
Can I ask you one question?
Yes, go ahead.
When you talk about subsidies, nobody gives the numbers. I do not believe that the subsidies are given to reduce the deductibles of $5,000 or more, and I do not think that they reduce the 40% co-insurance on the cheapest plan. So to me, it's a bunch of baloney.
Well, so let's be clear. So in terms of how the subsidies work, it's based on your percentage of income, and the closer you are to 138% of the federal poverty level, the bigger subsidy you get towards your premium, and no, that's not correct. It is the subsidies based on the cost of the second lowest priced silver plan in the exchange. But if you're under 200% of the federal poverty level, there's also cost sharing in terms of out-of-pocket costs as well. And so basically, if you're lower income, you get, for the money, you're able to get a higher level plan. And when you hit about 200% of the federal poverty level, that goes away. And then so the silver plan is a $2,000 deductible plan. So one could argue there is a gap, there's a group there between 200% and 300% of the federal poverty level. If you're earning $30,000 a year and that's a $2,000 deductible plan. The cost that you're going to pay out of pocket is about $200 a month. If you're living in a high-cost city like San Francisco, that can be a lot to do. So there are, sort of compared to the world we were in before the ACA, those people have a lot more resources to get health coverage. On the other hand, some of them will determine that it's too expensive and they can't afford it. And I think Anthony's point, some other states are looking at increasing those subsidies. So in Vermont, across the board, there's an increase, that states putting in money to increase the subsidies available, and Massachusetts and New York are doing it for lower income families.
I do want to move on to other questions. I'll just add to that, I don't know a lot about comparative costs globally, but I do know like of a couple of Western European countries. I mean, I think we have this belief that it's just significantly better there and much more manageable for people. But I do know in the Netherlands, this is a significant issue that people are seeing costing. They also have a private health insurance system. Their costs per person are increasing. I mean, there are other, it's not just the United States, it's other, we think, more socially advanced countries in the rest of the world. And yes, we have a question in the back of the room right here, please. Wait for the microphone. Wait for the microphone, please. And say your name at the beginning, please.
Ramon Castablanc, I'm a visiting scholar here. Netherlands just reversed some of their cost containment policies over the last few years, and we are now seeing the results of what happened in the Netherlands, where they let go of some of their controls of prices and costs. But here in the United States, I think that post-ACA, the next big issue is going to be affordability and what do we do about costs here in the United States. We've covered now many millions of more people than who were covered in the past, but we look at CBO or CMS projections for what share of our GDP is going to be going to healthcare, and it's pushing 20% by the year 2022 or something like that. So I'm wondering what trends we might be seeing going forward addressing the issue of affordability.
So you mean affordability? It sounds like you're asking two questions.
Cost of
affordability
healthcare
to people, but there's affordability to our society.
Right. Well, we're passing through very high prices. We're passing through the cost of many unnecessary medical procedures. Those then turn up in the insurance premiums and then get passed through as deductibles and copays and so forth. But at some point, we need to go upstream of all these costs and look at the medical care system that's running them up and start to see what we're going to do about that. And my question is what policies are coming forward in that area.
Let Larry have a turn. Go ahead.
So this is a really important question, because if the cost curve doesn't bend, then a lot of what we're talking about is not going to be affordable. So, and there's a pretty interesting discussion now going on, but there's no doubt that costs have come down dramatically, and particularly what we refer to as the health inflation rate, which is the rate of growth. If you go back to the 80s or so, it was the 16% range. The early part of the 21st century, it was a 9% range. Over the last 4 to 5 years, it's now fallen to 3 to 4% range. It's now the lowest rate of increase in 50 years. And there's some discussion as to how much of the economic slowdown and the sluggish so-called recovery is going on is contributing to that, and that's no doubt a factor. But I think a growing number of people are also saying that the Affordable Care Act is either reinforcing patterns that were going on or contributing in unique ways. We're seeing changes in medical delivery. One example is, for instance, as part of the penalty in Medicare for hospital readmission, we've now seen a pretty significant drop in that. We've seen premiums go down about 15%. In overall, if you look at the CBO report, it actually is reporting now that the impact because of the slowdown will be about 1% less of GDP being spent. So there's a pretty significant change. It has to do with delivery care reforms that are going on. It also has to do with very important payment reform efforts that are going on. I think it's too early to declare victory, and I think if you look at the CBO report, they're actually predicting somewhat of an increase, but it's still going to be substantially below anything we've seen in many decades. So I think on this issue, there are some good things to be hopeful about, but I think there's also many stakeholders who would like to reverse what the ACA did put into place, which would be very simply, this was tax reform. Mm-hmm. This was tax reform. People were talking about tax reform. The ACA was tax reform. It increased the taxes on the most affluent in terms of the Medicare payroll tax, and then it did something quite extraordinary. It introduced a brand new tax to social insurance, which was not on payroll, it was on capital gains. We've never seen that before. In addition, there were charges to the major stakeholders, to the pharmaceutical industry, medical device industry, insurers, and hospitals. All of that has brought in an enormous amount of revenue to the point that when someone like Paul Ryan now talks about his new budget, when he eliminates the Affordable Care Act, it increases the deficits because of the money coming in. So there are a number of changes going on here. They're very substantial. They've been largely hidden from public view and not really talked about. But it is, I would say, opening the opportunity for a new period in American cost control.
I just want to say, I think California has a real opportunity. One of the things Anthony mentioned was that Covered California is an active purchaser rather than a sort of an e-insurance go and buy anything. And if Covered California then has some ability to foster delivery system reform through really pushing sort of various kinds of standards on what kind of plans it wants to see. If you put that together with CalPERS, with the LA public system, sort of all the public Medi-Cal, all the public payers in the state. In a place like a county like Los Angeles, you're talking over half the market. So there is an ability now to influence the health insurance market and use that in a way that drives delivery system reform that could bring about some longer-term slowdown in healthcare costs. It's an opportunity. Doesn't mean it will be taken. It's something that should be done.
Okay.
And I would just note quickly that Massachusetts, after it passed its reform in 2006, passed and which avowedly did not even broach the issue of cost control or cost containment when they passed their expansion in 2006, followed up, because it was the logical next step, on a cost measure that included the global budget and some other key elements in 2010. In California, we're starting to see the beginnings of that both in the legislature and conversations about an all payers claims database and things like that, as well as on the ballot. This November, you are likely to see at least one measure on insurance rate regulation and another measure on capping hospital prices. So that gives you a sense that this is, again, this is not the end of the conversation.
Hey, right here?
I have a question about...
can you wait for the mic, please? And then please say your name when you start off.
my name is Claudette Berger, and I work here at the university, and I'm a member of the Teamsters. So I'm interested in what hasn't been raised, as far as I can tell. I missed the first speaker, I'm sorry, about the relationship with employer-based insurance plans, whether it's unions or based plans or not, the whole impact here, aside from the target kind of things. So as I understand it, these kind of plans may really suffer, or the people who are covered by them may suffer by these changes. And I don't know the details. I've just seen little snippets and articles. If you could all speak to it.
The so-called Cadillac plans?
Well, so there are a number of there are a few issues that affect union trusts, and that's sort of where some of this conversation has gone into. One is there are these per head fees. One of them is to fund to provide a fund to support basically reinsurance in the individual market as all of this gets going. There was a lot of fear as you start out, well, what happens if insurers misprice the plans? And so for the first few years, you have a number of steps in place to help out if the risk mix turned out to be less healthy than projected. And so that's paid for by what people call it a belly button fee, $63 per head for the next 3 years. It adjusts each year for everybody in any private insurance plan. And so So this would be all job-based plans as well. And so one of the arguments on the union trusts is, well, wait a minute, we understand why Blue Cross would pay this on all their lives. They're benefiting from being in the exchange. Why are we paying it on our union trust? We're not an insurance company. We're not benefiting. We're not part of the exchange. The one place the unions do benefit, of course, is if members lose their job, if they're out of work. This is a place they'll go and they may gain some coverage through that. But so that has been one of the issues, is a set of unions is asked if they not need to do so. Where the other thing that comes up is in 2018, the excise tax goes into effect. And what the excise tax does, and it's a really sort of a blunt instrument, it says, at that point, the cost of any health insurance plan over a certain amount, there will be a 40% excise tax on that amount. It was sort of interesting. Rather than just saying it's only tax deductible up to a certain point, they did it as an excise tax, but it comes out the same way. The argument there has always been that the tax benefit for coverage is regressive, that higher income people get more of a tax benefit than lower income people, and that higher cost plans, which are more likely to go to higher income people, get the biggest benefit. The other side of that is, in case of union plans, people have bargained wages into benefits over a long period of time and have put a premium on benefits. And while there is rating for age and geography, there is rating for age and gender, right? There's no it's
rating in Cover California.
No, within the excise tax.
Oh.
So it is adjusted by age and gender. It's not adjusted by geography, And so if one happens to work in a place that is just an expensive market, you work in a rural area, or you happen to work in a place where lots of your coworkers are sicker than average, then your health costs are going to be higher and you could be hit with the excise tax. So it's something that unions have been concerned about quite a bit and did a lot to try to push back on it when it was first put into place. Overall, as I said earlier on job-based coverage, I think the declines in job-based coverage we're going to see are really quite small. We could all be proven wrong here. Our estimates are really similar to the CBO's, where we think that overall you'll have some churn, but mainly it's really lower income workers where they can get subsidies outside that are bigger than the tax benefit. But the real issue here in a competitive world is you have some unions who represent industries that are competing against, where their competition is low-wage workers. So in the retail industry, in the restaurant industry, hotel industry, laborers, this is a concern that their competitors will be relying on these programs while their overhead for coverage is quite high, and that it could hurt their competitive position.
Larry Jacobs?
So I just want to respond very directly to your question. If you go back to World War II, when there were limits or outright bans on labor wage increases, there was a deal struck which said, we're going to give you a tax break if you take on these non-wage benefits, health insurance. And so unions worked for decades to build that up. But that didn't stop the employer from basically trying to change the deal. And so we've seen from kind of like the 1940s and the 50s was insurance coverage through what I would describe as an occupational welfare state, 2/3 to 3/4 of Americans being covered. It's now like plummeted. And there was a recent Gallup survey that came out that put the number at maybe under 50% now. Now that's not really about, frankly, the Affordable Care Act. That's about employers saying, we're either not going to offer anymore, or we're going to give you a terrible deal. Target Corporation in Minnesota, for instance, said, we're going to have you pick up more of the cost, and we're going to have the plans cover less. And then the cost sharing has also gone up. So there's a dramatic change in the nature in which employers are approaching this. And that's being, kind of the Affordable Care Act, in some ways, there may be some of these effects, but they're going to be small. The bigger part is just that the employer is essentially reneging on what had been the deal struck in World War II.
Woman.
Go ahead, please. Someone have a question in the back? So, yes, sir, right here.
John.
Okay, John Elwood. I'm in public policy around here. This is a hypothetical. What happens to all your worlds when the Republicans gain the Senate? And there's a 50% chance of that happening.
Well, I think if the Republicans gain the Senate in November, it's not going to change a whole lot, to be honest with you. I mean, the president is not going to back down on this. He doesn't. They've already given up on the idea that there's going to be a fix-it bill going through Congress, and they're using the expanded executive power that Richard Nixon and Reagan and Bush have created to use rulemaking, to use executive orders, administrative processes to make some very significant change. Also, having read the Affordable Care Act a number of times, it is filled with language like, it gives tremendous amount of discretion to the Secretary of Health and Human Services. So I'm not anticipating, frankly, a whole lot of, kind of dramatic changes. I think there could be some efforts to ratchet back subsidies in some area. I did a paper recently in Health Affairs with Joel Arrio, who's the first exchange director, and Joel and I interviewed a bunch of people and then did some research, and the conclusion we came to is that when we go to the stakeholders, the big insurers, pharma and others, and you talk to them and they say, oh, we've got all these problems, we'll say, fine. Do you want to go back to 2009? Oh, no, not that, because there's a whole new market that's formed. So I think as soon as the Republicans come in and actually had power, rather than being opposed to something and tried to pass things, and if it was a kind of draconian passage, they're going to find that the interests they think are on their side have changed. And it's not going to be uniform, but it's going to be a real fight. And it's going to be a fight among people who have now made massive investments in this new system and see it as, in some ways, preferable to what they had before 2009.
Can I continue? Medicaid is an annual
Yes.
appropriation. I mean,
Yep.
it's appropriated entitlement. So if I was a good Tea Party right-winger, I'd go after you in terms of the appropriation for Medicaid expansion.
Again, though, you've got all these Republic.
But it's automatic, right? I mean,
it's-
it doesn't require an act of Congress for those, either the subsidies in exchange or the disbursements to Medicaid to do it. So it's not like the Congress has to make the appropriation. It is that 90% of the law is automatically funded.
Right,
And so,
exactly, yeah.
and so then that creates my concern would be if if Governor Romney had won the presidency, that would have been a real threat to the Affordable Care Act. The next real threat to the Affordable Care Act is in 2016 election, 2017. But by then, that's 3 years into, and that's 3 years of enrollment. That's 3 years of the building up that Ken mentioned, et cetera. Sorry.
So there's a question. I recognize that we're over time here, and we started a little late, so I think we'll take you and maybe one more, and that'll.
Thank you. Very much enjoyed the panel. I have a question about what the road forward is at the state level. What is going to happen? What can be done? What are people thinking of doing at state levels to improve things further? What are some of the ways people are hoping to morph what exists now into more of a, I don't know, public option structure or other creative options?
Well, Margaret and Charlie, we haven't heard a lot from you, and I'm just wondering how all the community stakeholders that we've heard from, and how much capacity there is there, and how much of an impact you expect that's going to have.
Well, you've got some of the stakeholders at the table, so if you want to know what they're going to, and some of the community groups at the table, so if you want to know what they're going to be pushing, it's better to ask them. As to their capacity to do it, it's higher than it's ever been for the reasons that we've described. They've got, one thing that we didn't get to say in the presentation is that, way back when Health Access was founded in the 1980s, it was very dependent for particularly things like lobbying and electoral mobilization and grassroots mobilization on labor. But many of the groups that are part of the Health Access Coalition, many of the community-based organizations, have developed pretty substantial grassroots capacity, perhaps not that to match labor, but and they've gained from doing things like monitoring, they really are at the front lines of enrolling people in Medi-Cal and in the healthcare exchange. And from that, they've got all of this firsthand knowledge and all of these grassroots ties to the people who are benefiting from the law or who are not benefiting because of problems in the law, which gives them this firsthand knowledge to know what are the kind of fixes to propose and what are the kind of stories and truths that we need to tell in order to win those fixes. What those fixes are things that Anthony and Ken can tell you better.
Anthony, Ken?
So,
What's
so first of all, it's fascinating to be, on a panel when you're getting X-rayed at the same time in terms of having your board there. I will let me just say in response to those earlier comments that it is fascinating to have that sort of academic analysis of our role in the world. I will say that number one, I wasn't there for the founding of Health Access. I'm the 5th executive director of my organization, there for 12 years. But and number two, it is credit to a broader, and I'm sure that they would agree that Health Access is a central healthcare coalition, but